Welcome back to the Deep Dive. Today we are tackling something truly enormous. We're aiming for what you might call elite professional mastery of the circulatory and lymphatic systems.
Absolutely. And this isn't just about, naming the parts like in basic biology. We're going deep into the microscopic architecture, the histology, that underpins how this entire system functions. It's fundamental to life itself.
And the scale is just, well, it's hard to grasp. We're talking about a network of vessels, blood and lymphatic, that if you laid it all out, could stretch 100,000, maybe even 150,000 kilometers in an adult.
It's staggering. Think about that it could circle the Earth 3, maybe 4 times. Our sources for this are, well, they're foundational histology texts, the kind specialists rely on. So we're really digging into the details, the why behind the structure.
Okay, so 150,000 kilometers, let's break it down. We've got two main systems to get our heads around, right? The blood vascular or cardiovascular system, and then the lymphatic vascular system.
Exactly. 2 interconnected networks. And within the cardiovascular side, you have the components most people know. The heart, the pump, obviously. Then the arteries, carrying blood away from the heart, branching out.
The efferent vessels.
Right, efferent. Then the veins, the afferent vessels, bringing blood back towards the heart, merging and getting bigger. And crucially, in between, the capillaries. Tiny, tiny vessels. But that's where the real exchange happens.
Oxygen, CO2, nutrients, waste. It all crosses the capillary walls.
Yeah.
And you mentioned this term, the microvasculature.
Yes, that's the functional unit at the tissue level. It's this incredibly complex branching anastomosing is the technical term network of the smallest arterioles, the capillaries themselves, and the smallest venules. It's the business end of the system.
And don't forget the 2 big loops. The pulmonary circuit.
The quick trip to the lungs and back for oxygen, relatively low pressure.
And then the systemic circuit, the big one. Delivering everything to, well, everywhere else in the body and picking up the trash.
That's the high-pressure long-haul circuit. And our mission, if you want that elite mastery, is to see how the microscopic structure, the layers, the cell types, the matrix, explains the function of every single part of this vast network. But, before we even get to the heart or the big vessels, we absolutely have to start with the endothelium.
The endothelium. Okay. It sounds simple. A single layer of cells lining everything.
It sounds simple, but it's arguably the most functionally critical tissue in the whole system. It's a simple squamous epithelium, yes, but it lines every single blood vessel, every lymphatic vessel, the heart chambers. It's the universal interface between the blood or lymph and the surrounding tissues.
So it's more than just wallpaper.
Oh, much more. Think of it as the circulation's highly active inner skin. It's not passive at all. If you're aiming for mastery, knowing its functions is non-negotiable.
Okay, function number 1. You said it maintains a barrier, but a selective one.
Right, it controls what gets across. But even more critically, perhaps, is its role as an antithrombogenic surface. It actively prevents blood clots from forming.
That sounds vital. What happens if that fails?
Catastrophe, basically. Widespread clotting. The endothelium secretes molecules that actively inhibit platelet aggregation and coagulation. It has to maintain this perfect balance, keep blood liquid, but be ready to plug a leak instantly.
That makes sense. What's next?
Immune cell trafficking. The endothelium decides where and when white blood cells leave the bloodstream to enter tissues. Think inflammation, infection. The endothelium puts up the signals, the exit ramps, for these immune cells. It controls the immune response at the local level.
So it directs the traffic for immune cells. And the third big one?
Paracrine control, local signaling. Endothelial cells release chemical messengers, paracrine factors, that act on the smooth muscle cells right next to them in the vessel wall. This controls vasodilation, making the vessel wider, and vasoconstriction, making it narrower.
So it fine-tunes blood flow locally.
Precisely. And it also releases growth factors that influence the health and structure of the vessel wall itself. It's a constant chemical conversation happening along that entire 150,000 kilometer length.
Okay, that sets the stage. Before we dive into the heart, maybe just quickly recap the basic flow path and where the blood actually is most of the time.
Sure. Heart pumps. Arteries carry blood out, branching smaller and smaller. Capillaries, the microvasculature, handle the exchange. Venules collect the blood, merging into larger veins that return it to the heart. Simple path.
And the distribution. If we took a snapshot.
Right now in you, about 70% of your blood volume is cruising around in the systemic veins and arteries. About 18% is in the pulmonary circuit, going to and from your lungs, and only about 12% is actually inside the heart chambers at this exact moment. Most of it is out there doing its job.
Okay, 70% out in the field. Now let's zoom in on the engine, the heart. Its walls aren't uniform, they're specialized layers.
3 distinct layers working together. We'll go from the inside, lining the chambers, outwards. First is the endocardium.
Which includes that endothelium we just discussed.
Exactly. It's the endothelium plus a backing layer of fibroelastic connective tissue. And then crucially, deep to that is the subendocardial layer. This isn't just connective tissue, it's the specific zone where parts of the heart's electrical impulse conducting system run.
So the wiring is embedded right there in the inner layer. Okay, moving out.
We hit the powerhouse, the myocardium. This is the thick muscular layer. It's cardiac muscle fibers arranged in complex spirals. And the key thing here for understanding function is the variation in thickness.
It's not the same thickness everywhere.
Not at all. It's much thicker in the ventricles compared to the atria, which makes sense. They do more pumping work. But the really dramatic difference is between the ventricles. The left ventricular myocardium is significantly thicker than the right.
Why such a big difference?
Physics, essentially. The left ventricle has to generate enormous pressure to push blood out against the high resistance of the entire systemic circulation head to toes. The right ventricle only needs to pump blood next door through the low-resistance pulmonary circuit to the lungs. The thickness directly reflects the workload.
Structure dictates function, loud and clear. Okay, the outermost layer.
That's the epicardium. It's actually the visceral layer of the pericardium, the sac the heart sits in. So it's lined by a simple squamous mesothelium, similar to endothelium, but facing a body cavity supported by loose connective tissue. This layer contains the coronary arteries and veins, nerves, and often a fair bit of adipose tissue for cushioning.
And it makes lubricant.
Yes. The mesothelial cells secrete pericardial fluid, which allows the heart to beat constantly within the pericardial sac without friction.
Now, besides these 3 wall layers, there's another crucial structural component you mentioned, the fibrous cardiac skeleton. Sounds architectural, but you hinted it's vital electrically.
It absolutely is. It's made of dense, irregular connective tissue, primarily located around the bases of the valves and between the atria and ventricles. Yes, it provides physical support anchoring the valves, giving the cardiac muscle something firm to pull against. But its most critical role, electrical insulation.
It insulates the atria from the ventricles. Why is that so important?
Think about it. If the electrical wave of depolarization just spread freely from the atrial muscle directly into the ventricular muscle, they'd contract almost simultaneously, or at least without coordination. Pumping would be incredibly inefficient, maybe even chaotic fibrillation.
So it forces the signal to take a specific route.
Precisely. The fibrous skeleton ensures there's only one path for the electrical signal to get from the atria down to the ventricles, and that's through the specialized conducting system, specifically the AV bundle. This creates the necessary delay for the atria to finish contracting and fill the ventricles before the ventricles pump. It orchestrates the heartbeat.
Perfect segue to the impulse conducting system itself. These aren't nerves, right? They're modified heart muscle cells.
Correct. Highly specialized cardiac muscle fibers optimized for generating and rapidly conducting electrical impulses. The whole process starts at the sinoatrial SA node, often called the pacemaker. It's located up in the wall of the right atrium.
And how do these SA node cells look different under the microscope?
Histologically, they're distinct. They tend to be smaller than regular contractile cells. They stain paler, have fewer myofibrils, and fewer of the typical intercalated discs that connect heart cells. Their job is initiation, not forceful contraction. They spontaneously depolarize at the fastest rate, setting the heart's rhythm.
Okay, pacemaker files. Where does the signal go next?
It spreads through the atrial muscle, causing the atria to contract, and it converges on the atrioventricular AV node, which sits in the floor of the right atrium near the septum.
Yeah, the AV node's role.
The cells here are similar to the SA node cells. The AV node's crucial function is to introduce a slight delay, about 0.1 seconds. This pause is vital. It ensures the atria have fully ejected their blood into the ventricles before the ventricular contraction begins, maximizes filling.
So SA node initiates, AV node delays. Then where?
The signal then enters the AV bundle, or bundle of His. This is the structure that penetrates the insulating fibrous skeleton, carrying the impulse from the atria into the interventricular septum. Once through the skeleton, it quickly divides into left and right bundle branches.
And these branches lead to the final distributors.
Yes, they travel down the septum and then branch out into the ventricular walls, terminating in the Purkinje fibers. These form a network in the subendocardial layer, remember, that layer just deep to the endothelium.
How do we spot Purkinje fibers histologically? They sound important for coordinating the big ventricular squeeze.
They are very distinctive. They are much larger in diameter than the surrounding contractile cardiac muscle fibers. They stain very pale because they have sparse myofibrils, which are pushed to the periphery of the cell, and they contain large amounts of glycogen.
Why so much glycogen?
It's thought to be related to their high metabolic activity and perhaps resistance to hypoxia. But the large size and specialized junctions mean they conduct the impulse extremely rapidly, much faster than regular myocardium. This ensures that the depolarization spreads quickly and synchronously throughout both ventricles, starting from the apex and moving upwards, leading to an efficient, coordinated contraction that ejects blood effectively.
So this whole intrinsic system sets the basic rhythm and coordination. But the nervous system can tweak it, right?
Definitely. There are autonomic nerve fibers and ganglia, particularly near the SA and AV nodes. The parasympathetic system, mainly via the vagus nerve, cranial nerve X, releases the acetylcholine, which slows down the heart rate. The sympathetic system releases norepinephrine, which accelerates the heart rate and increases contraction force.
And there are sensory nerves, too.
Yeah.
Feeling pain.
Yes, there are afferent nerve endings in the heart tissue that register stimuli like stretch and, importantly, pain due to ischemia, lack of oxygen. That's the basis of angina pectoris, the chest pain often felt when coronary arteries are narrowed and the heart muscle isn't getting enough blood during exertion.
Let's connect this to a common clinical finding, heart murmurs. These relate to the valves, which are basically folds of endocardium.
That's right. Structurally simple, but functionally critical. If a valve is damaged, maybe from a birth defect or an infection like rheumatic fever or even chronic high blood pressure, it might not close properly. This leads to regurgitation, blood leaking backward through the valve when it should be closed.
And that backflow creates noise.
Exactly. The turbulent blood flow causes audible vibrations, which are the murmurs a doctor hears with a stethoscope. If the valve defect is severe and chronic, the heart chamber upstream has to work much harder to compensate, which can lead to hypertrophy or enlargement of that chamber, eventually leading to heart failure.
What about replacing valves? You mentioned the endothelium earlier.
Yes, a major challenge. Whether you use a mechanical valve or a biological one, like from a pig or cow, it won't have the patient's own intact, functional endothelium covering its surface.
And without that antithrombogenic surface.
The blood will immediately try to clot on the foreign material. It's a huge risk. That's why anyone with an artificial heart valve must take anticoagulant medications like warfarin or newer agents for life to prevent dangerous thrombus formation on the valve.
That endothelium just keeps coming up as critical. Okay, let's move out from the heart now and into that vast network of vessels. You said anything larger than a capillary generally follows a three-layer plan, the tunics.
Right. Once you get beyond the microvasculature, arteries and veins share this basic concentric structure. The specifics vary hugely depending on the vessel type and function, but the blueprint is there. It's shaped by blood pressure forces and the local tissue needs.
Before we detail the tunics, tunica, intima, media, adventitia, let's revisit the endothelium-specific jobs now that we're in the vessels proper. You mentioned clot control. What exactly does it secrete?
It's a chemical factory for hemostasis. To prevent clotting, it releases things like heparin, an anticoagulant, tissue plasminogen activator, TPA, which breaks down existing clots, and prostacyclin, inhibits platelet aggregation. But it also holds factors ready to promote clotting when needed, like von Willebrand factor, which is crucial for platelets sticking to an injury site. It's a dynamic balance.
Okay, and controlling vessel diameter, vasoconstriction and dilation.
Absolutely key for blood pressure and flow regulation. Endothelial cells secrete potent vasoconstrictors, the best known being endothelin-1. They also make angiotensin-converting enzyme, ACE, which is involved in producing angiotensin II, another strong constrictor.
Which is why ACE inhibitors are used to treat high blood pressure.
Precisely. And to counter that, they produce vasodilators, most famously nitric oxide, NO, a gas that causes smooth muscle relaxation, and also prostacyclin again, which has vasodilator effects too. This local control is happening constantly.
Amazing. And the third role you mentioned, inflammation and immune cell recruitment.
This is huge, especially in the venules. When there's tissue injury or infection, the endothelium gets activated. It needs to signal passing white blood cells, WBCs, to stop and exit into the tissue. One of the very first rapid steps involves specialized storage granules inside the endothelial cells called Weibel-Palade bodies.
Weibel-Palade. What do they do?
They're pre-packed with molecules like p-selectin and von Willebrand factor. On stimulation, these granules quickly fuse with the cell surface, dumping p-selectin onto the luminal side. P-selectin acts like molecular Velcro, catching passing leukocytes and causing them to slow down and roll along the endothelium the first step before they firmly adhere and migrate out. The endothelium also releases interleukins and other chemokines to orchestrate the inflammatory response.
Wow, so it's pre-made grab handles ready to deploy instantly. And growth and repair.
Yes, it's central to building and maintaining the network. Endothelial cells secrete vascular endothelial growth factor, VEGF, which is the master signal for angiogenesis, sprouting new capillaries from existing vessels, essential for wound healing, development, but also, unfortunately, for tumor growth. They also secrete angiopoietins, which help stabilize new vessels by recruiting smooth muscle cells and parasites to form the vessel wall.
Given all these vital functions, endothelial damage seems like the root of many vascular problems, like thrombosis.
It absolutely is. Damage from physical injury, inflammation, high cholesterol, smoking, diabetes disrupts that non-thrombogenic surface. The underlying subendothelial collagen gets exposed. Collagen is like a red flag to platelets. They immediately stick, activate, and initiate the coagulation cascade, forming fibrin. That's how you get a thrombus, a blood clot attached to the vessel wall.
And the real danger is when that thrombus or a piece of it breaks loose.
Exactly. That piece becomes an embolus, traveling downstream until it gets stuck in a smaller vessel, cutting off blood supply. That's the mechanism behind ischemic stroke in the brain, pulmonary embolism in the lungs, or heart attack, myocardial infarction in the coronary arteries. Maintaining endothelial health is paramount. And clinically, if we catch a thrombus early, we can sometimes use drugs like TPA, that clot buster the endothelium itself makes, to dissolve the fibrin and restore flow.
Okay, it's clear the endothelium is far more than a liner. Now, let's get back to that three-layer structure of larger vessels, the tunics, starting from the inside, lining the lumen.
Tunica intima, innermost layer. It always consists of the endothelium itself, plus a thin subendothelial layer of loose connective tissue. Sometimes you find a few scattered smooth muscle cells in there too. In arteries, a key feature of the intima is the internal elastic lamina.
Elastic layer.
Yes, a distinct sheet of elastin, often looking wavy in cross-sections. It has holes or fenestrations in it, which allow nutrients to diffuse from the blood deeper into the vessel wall. This internal elastic lamina marks the boundary between the intima and the next layer out,
Which is the tunica media, the middle layer.
This is usually the thickest layer, especially in arteries. It's primarily composed of smooth muscle cells arranged in concentric, helical layers. Interspersed between the smooth muscle cells are variable amounts of elastic fibers, elastic lamellae in larger arteries, reticular fibers, collagen type 3, and proteoglycans.
And the smooth muscle cells make all that connective tissue.
Yes. Unlike fibroblasts elsewhere, the vascular smooth muscle cells synthesize the collagen, elastin, and ground substance of the tunica media. In larger arteries, there might also be an external elastic lamina separating the media from the outermost layer.
And that outermost layer is the tunica adventitia, or tunica externa.
Right. This is mainly connective tissue, typically dense, irregular, with lots of type I collagen fibers and elastic fibers. It provides structural support and anchors the vessel to the surrounding tissues. Its connective tissue merges with the stroma of the organ the vessel is in.
Now, these vessel walls, especially in big arteries and veins, can get pretty thick. How do the outer layers get oxygen and nutrients if diffusion from the lumen isn't enough?
They need their own blood supply. This is the vessa vasorum, literally, vessels of the vessel. These are tiny arterioles, capillaries, and venules that arise either from the main vessel itself or from nearby arteries, and they penetrate the adventitia and the outer part of the media.
So the vessel wall has its own circulation. Interesting. Is it more common in arteries or veins?
It's generally more prominent in large veins. Think about it. The blood inside a large vein is deoxygenated and nutrient poor, so the vessel wall relies more heavily on the vasa vasorum. Arterial blood is oxygen-rich, so diffusion from the lumen can nourish a greater thickness of the wall.
Makes sense. And nerves. How is vessel diameter controlled?
Through vasomotor nerves. These are mostly unmyelinated sympathetic nerve fibers that travel within the adventitia. They release norepinephrine, which acts on the smooth muscle cells in the media, causing vasoconstriction. Arteries generally have a denser nerve supply than veins, reflecting their greater role in regulating blood pressure and flow.
Okay, we have the three tunics and the support systems. Now let's use this to classify the arteries, starting right from the heart's exit. The biggest ones, elastic arteries.
Also called conducting arteries. This is the aorta, the pulmonary artery, and their immediate major branches like the brachiocephalic, common carotids, subclavians. Their structure is dominated by elastin.
How so?
Their tunica media is incredibly thick, but instead of being mostly muscle, it consists of maybe 40 to 70 concentric sheets, or lamellae of elastin, alternating with thin layers of smooth muscle. The tunica intima is also well developed, often with smooth muscle cells in the subendothelial layer. The adventitia is relatively thin compared to the media.
And the function of all that elastic tissue. It's about handling pressure pulses.
Exactly. They act as a pressure reservoir or a Windkessel. During systole, when the ventricle ejects blood, these elastic walls stretch, absorbing the pressure surge and storing potential energy. During diastole, when the ventricle relaxes, the elastic recoil of the walls maintains diastolic pressure and pushes the blood forward smoothly. It turns the heart's pulsatil output into relatively steady flow downstream.
Like a shock absorber for the circulation.
Yes.
And their main disease is atherosclerosis, which we touched on.
Yes, atherosclerosis hits elastic and large muscular arteries hardest. That process damaged endothelium, LDL oxidation in the intima, monocyte recruitment leading to lipid-laden foam cells forming fatty streaks, then complex fiber fatty plaques called atheromas disrupts the wall structure.
And the outcome depends on the artery type.
Generally, yes. In elastic arteries like the aorta, the destruction of the elastic lamellae weakens the wall, making it prone to dilating and forming an aneurysm, which can rupture catastrophically. In muscular arteries, the plaque tends to grow inwards, narrowing the lumen stenosis and potentially leading to ischemia downstream, like in the coronary arteries, causing angina or heart attack.
Before we move down the arterial tree, these large arteries also house crucial sensors.
Right, the arterial sensory structures. We need to monitor pressure and chemistry. For pressure, we have baroreceptors. These are located mainly in the carotid sinuses, dilations of the internal carotid arteries in the neck, and in the wall of the aortic arch.
How are they specialized histologically?
The carotid sinus wall has a relatively thin tunica media, making it more easily distensible by pressure changes. The adventitia in this region is packed with sensory nerve endings from the glossopharyngeal nerve, CNI. High pressure stretches the wall, firing these nerves, which signal the brainstem to lower blood pressure, for example by slowing heart rate. The aortic arch baroreceptors work similarly but signal via the vagus nerve, CNX.
And chemical sensors.
Those are the chemoreceptors found in small, discrete structures called the carotid bodies, near the carotid bifurcation, and aortic bodies, near the aortic arch. These are technically paraganglia.
Paraganglia. What do they contain?
They contain specialized glomus cells, which are derived from the neural crest. These cells are packed with vesicles containing neurotransmitters like dopamine and acetylcholine. They are supported by satellite cells and are surrounded by a rich network of fenestrated capillaries. The glomus cells directly sense changes in blood O2 levels, especially low O2 hypoxia, CO2 levels, and pH acidity.
And when they detect a problem, like low oxygen,
they release neurotransmitters that stimulate afferent nerve endings, CNIX for carotid bodies, CNX for aortic bodies, signaling the brainstem respiratory and cardiovascular centers to increase breathing rate and adjust circulation to compensate.
Okay, vital feedback loops. Moving downstream from the elastic arteries, we get to the muscular arteries.
Also called distributing arteries. This category includes most of the arteries you can name: brachial, femoral, radial, renal, etc. Their main job is to distribute blood to specific organs and regions and to help regulate blood pressure through vasoconstriction and dilation.
What's their defining histological feature?
A very prominent, easily visible internal elastic lamina separating the intima from the media. Their tunica media is thick and dominated by smooth muscle, anywhere from a few layers up to maybe 40 layers, with much less elastic material compared to elastic arteries. A distinct external elastic lamina is usually present only in the larger muscular arteries. The adventitia is often quite thick as well.
So less elastic recoil, more active contraction.
Exactly. Their diameter is primarily controlled by the autonomic nervous system acting on that thick muscular media.
And finally, before we hit the capillaries, the arterioles, the resistance vessels.
Yes, this is where the main drop in blood pressure occurs across the circulation. Arterioles mark the beginning of the microvasculature. They're small, typically less than 0.1 millimeters in diameter. A key identifying feature is that their wall thickness is roughly equal to the diameter of their lumen.
What about their tunic structure?
The intima is just endothelium. The subendothelial layer is very thin or absent. The internal elastic lamina is usually absent or very thin. The tunica media is the key player. It consists of only 1 or 2, maybe 3 layers of smooth muscle cells encircling the endothelium. The adventitia is thin and inconspicuous, merging with the surrounding connective tissue.
So that thin but muscular wall gives them their function.
Absolutely. Even at rest, the smooth muscle in arterioles maintains a state of partial contraction or tone. This tone creates significant resistance to blood flow. By adjusting this tone, constricting further or relaxing, the arterioles act like taps, controlling blood flow into the downstream capillary beds, and collectively, they are the major determinants of systemic blood pressure.
Which links back to high blood pressure, hypertension.
Right. Much essential hypertension, high blood pressure with no single identifiable cause, is thought to result from a generalized increase in arteriolar smooth muscle tone, increasing peripheral resistance.
Okay. We've reached the exchange zone, the capillaries and the microcirculation.
Yeah.
This is where the action happens across that enormous surface area. You said 5,000 square meters.
Yeah, an incredible surface area packed into a tiny volume. Capillary density varies hugely depending on the tissue's metabolic rate. Very high in places like kidney glomeruli, liver, cardiac, and skeletal muscle. Much lower in tissues like tendons or ligaments.
And you mentioned flow isn't constant, it's pulsatile. How is that managed?
It's controlled at the entrance to the capillary bed. The final branches of arterioles are called metarterioles. These aren't quite true arterioles, not quite capillaries. They still have scattered smooth muscle cells along their length. At the point where true capillaries branch off the metarteriole, these smooth muscle cells form precapillary sphincters.
Little muscular cuffs.
Exactly. These sphincters act like gates. They open and close cyclically, maybe 5 to 10 times per minute, depending on local needs, like oxygen levels. Blood flows from the arteriole through the metarteriole, which can also act as a direct thoroughfare channel to the venule, and intermittently pulses into the true capillary network when the sphincters relax.
So most capillaries aren't full all the time.
No, not at all. At any given moment, most capillaries in a resting tissue bed might be temporarily closed off by their sphincters. This pulsed-off flow is very efficient. It means only about 5% of your total blood volume is actually in the capillaries at one time, even though they represent the vast majority of the vessel number and surface area.
Let's look at the capillary structure itself. Super simple. Endothelium and a basement membrane. Diameter.
Tiny, just 4 to 10 micrometers, often just wide enough for red blood cells to pass through in single file. This thin wall and narrow diameter maximize the efficiency of diffusion and transport across the endothelial cell. And wrapped around them, we find parasites.
Ah, yes, the cells hugging the capillaries. What do we know about them?
They are fascinating cells derived from mesenchyme that sit outside the endothelial tube but within the capillary basement membrane. They have long processes that wrap around the capillary. They contain contractile proteins like actin and myosin, suggesting they can influence capillary diameter or blood flow, especially in the CNS.
So they might help regulate flow locally. What else?
They secrete their own basement membrane components and other extracellular matrix molecules, contributing to vessel stability. They are crucial for forming and maintaining the blood-brain barrier. And importantly, they can act like mesenchymal stem cells if there's tissue injury. Parasites can proliferate and differentiate into fibroblasts or smooth muscle cells to aid in repair and angiogenesis.
Multifunctional cells. Now, for that elite mastery, you stressed differentiating the types of capillaries. It's all about permeability.
Exactly. The structure directly determines how leaky the capillary is. The most common type is the continuous capillary.
Where do we find those?
Muscle tissue, connective tissue, nervous tissue, forming the blood-brain barrier, lungs, exocrine glands. Their defining feature is that the endothelial cells are joined by extensive tight junctions, including junctions, severely restricting passage between the cells.
So how does exchange happen?
Almost exclusively through the endothelial cells themselves. Small lipid-soluble molecules can diffuse across the membranes. Water and small solids use specific channels. Larger molecules rely on transcytosis substances are enclosed in vesicles, penocytosis on one side, transported across the cell, and released on the other. Histologically, you see lots of these transport vesicles in continuous capillaries. They are the least permeable type.
Okay, type 2.
Fenestrated capillaries, found where you need rapid exchange of fluid and small solids, like in kidney glomeruli, the intestines for nutrient absorption, endocrine glands for hormone release, and the choroid plexus, making cerebrospinal fluid.
Fenestrated means windowed, right?
Exactly. The endothelial cells are perforated by numerous small circular openings or fenestrations, typically about 80 nanometers in diameter. These are often bridged by a very thin diaphragm, except in the kidney glomerulus. Critically, though, the basement membrane underneath remains continuous. It acts as a size and charge barrier. These are much more permeable than continuous capillaries, especially to water and small solutes.
And the third type, the leakiest of all.
Discontinuous capillaries, more commonly called sinusoids. These are found in the liver, spleen, bone marrow, and some endocrine organs. They are specialized for maximum exchange, allowing even large proteins and entire cells to pass through.
How are they structured for that?
Several key features. They have a much larger diameter, 30-40 micrometers, which slows blood flow significantly. The endothelial cells have large gaps between them and sometimes large perforations through the cells themselves. And most importantly, the basement membrane is discontinuous or completely absent. This allows free passage of plasma components and even blood cells between the sinusoid lumen and the surrounding tissue. Think new blood cells entering circulation from bone marrow or plasma proteins being processed by liver cells.
Structure perfectly matches function again. Are there any alternative routes in the microcirculation, ways to bypass capillaries?
Yes, the main one is the arteriovenous shunt, or anastomosis AV shunt. This is a direct connection, a short muscular vessel linking an arteriole directly to a venule, completely bypassing the capillary bed in that area.
Why have a bypass?
They are particularly important in thermoregulation, especially in the skin of the extremities, fingers, toes, ears. They are heavily innervated. When you need to conserve heat, sympathetic nerves cause the shunt to dilate, and the arterioles feeding the superficial capillary beds to constrict, routing blood directly back into the deeper venous system, away from the skin surface. When you need to lose heat, the shunts constrict, forcing blood through the surface capillaries for cooling.
Clever plumbing. Any other special pathways?
The other important one is the portal system. This isn't a bypass, but a unique sequence. Normally, blood goes artery, capillary bed, vein. In a portal system, it goes artery, capillary bed 1, portal, vein, capillary bed 2, vein.
Two capillary beds in series. Where does that happen?
The two classic examples are the hepatic portal system, intestinal capillaries, portal vein, or liver sinusoids, and the hypothalamic hypophyseal portal system, hypothalamus capillaries, portal veins, anterior pituitary capillaries. The advantage is that substances pick up in the first capillary bed, like digested nutrients in the gut or releasing hormones from the hypothalamus, are delivered directly and at high concentration to the second capillary bed, liver cells or pituitary hormone-producing cells, before being diluted in the general circulation. Highly efficient delivery.
Very elegant. Now, a clinical point about the microcirculation. Diabetic microangiopathy. What's going wrong there histologically?
In chronic diabetes, the high blood glucose levels cause widespread biochemical changes. One major consequence in the microvasculature is a diffuse thickening of the capillary basement membranes. This happens throughout the body, but is particularly problematic in the kidneys, leading to kidney failure, the retina, diabetic retinopathy, leading to blindness, nerves, and skeletal muscle. This thickened barrier significantly impairs the normal metabolic exchange across the capillary wall,
Making exchange less efficient. Okay, we've navigated the supply lines and the exchange zones. Now we head back towards the heart via the veins and venules. The return journey starts small.
It starts right after the capillaries with the postcapillary venules. These are small, 15-20 micrometers wide. Structurally, they're similar to wide capillaries, often still having parasites associated with them. Their key functional significance. They are the primary site where white blood cells adhere to the endothelium and migrate out into tissues during inflammation and infection, that process called transendothelial migration or diapedesis.
Why there specifically?
The endothelial cell junctions in postcapillary venules are the loosest in the entire microvasculature. They respond readily to inflammatory mediators like histamine and bradykinin, increasing their permeability. This not only facilitates WBC exit, but also allows significant plasma fluid to leak out, causing the characteristic swelling or edema seen in inflammation.
So they're designed to be a bit leaky when needed as they get bigger.
They transition into collecting venules and then muscular venules. They start acquiring a recognizable tunica media, usually just 1 or 2 layers of smooth muscle, and the adventitia becomes more distinct. They converge to form small veins.
And the veins themselves, small, medium, large. What are the general structural hallmarks? They're carrying blood back under low pressure.
That low pressure is key to their structure. Compared to arteries of similar overall diameter, veins have much larger lumens and significantly thinner walls. The 3 tunics are present, but often less distinct than in arteries.
How do the layers differ?
The tunica intima is thin, just endothelium, and a minimal subendothelial layer. The tunica media is also relatively thin, containing scattered bundles of smooth muscle and connective tissue, much less developed than in corresponding arteries. The standout layer is usually the tunica adventitia. It's often the thickest layer in veins, rich in collagen and elastic fibers. In the largest veins, like the vena cava, the adventitia even contains substantial longitudinal bundles of smooth muscle, which might help propel blood forward.
And the feature essential for overcoming gravity, especially in the limbs.
Valves. These are absolutely critical, particularly in medium and large veins below the level of the heart. Vein valves are thin, paired leaflets formed by infoldings of the tunica intima projecting into the lumen. They're reinforced with connective tissue and elastic fibers.
How do they work?
They passively prevent the backflow of blood. When blood tries to flow backward due to gravity or low pressure, the leaflets fill and are pushed together, occluding the lumen. When blood flows toward the heart, usually aided by contraction of surrounding skeletal muscles, which compresses the vein, the leaflets are pushed flat against the wall, allowing flow. They ensure unidirectional movement.
Okay, that wraps up the blood vascular system. But for complete mastery, we need the parallel network, the lymphatic vascular system. It starts with lymphatic capillaries.
Yes, the system begins as blind-ended tubes, the lymphatic capillaries, interwoven with the blood capillary networks in most tissues. Their job is to collect the excess interstitial fluid that leaks out of blood capillaries, plus any leaked plasma proteins, and return it to the blood. This collected fluid is called lymph.
Where don't we find them?
They are absent from bone marrow, cartilage, the epidermis, and most of the central nervous system, though the brain has its own related drainage system. But pretty much everywhere else you have blood microvasculature, you'll find lymphatics starting.
You said their structure is unique. How do they collect fluid so effectively?
They are beautifully designed for it. The endothelial cells forming the wall lack tight junctions and overlap loosely. They rest on an incomplete or discontinuous basal lamina. Crucially, there are fine anchoring filaments made of collagen that extend from the outer surface of the endothelial cells and attach to the surrounding connective tissue matrix.
What do the anchoring filaments do?
When interstitial fluid pressure rises, like during inflammation, it pulls on the surrounding connective tissue, which in turn pulls on the anchoring filaments. This actively pulls the lymphatic capillary open, widening the gaps between the endothelial cells, allowing fluid and proteins, cell debris, even migrating cells, to easily enter the lymphatic capillary lumen.
So increased tissue fluid opens the entry points. Clever. And the overlapping cells.
The overlapping edges of the endothelial cells act like one-way mini-valves. Fluid can push its way in between the cells, but when pressure inside the lymphatic capillary rises, it pushes these flaps shut, preventing lymph from leaking back out into the tissue space.
So fluid gets in that can't easily get out. These capillaries then merge.
Yes, lymphatic capillaries merge to form progressively larger lymphatic vessels. As they grow, their walls become slightly thicker, acquiring some connective tissue and smooth muscle, but the three tunics, intima, media, adventitia, are generally not clearly defined like in blood vessels.
Do they have valves like veins?
Yes, they have numerous valves, even more closely spaced than in veins. These are complete folds of the intima, ensuring that the lymph flows strictly in one direction centrally, back towards the bloodstream. Lymph movement relies heavily on external forces, like skeletal muscle contractions and respiratory movements, squeezing the vessel.
And along the way, the lymph gets filtered.
Absolutely. Lymphatic vessels are interrupted at intervals by lymph nodes, where the lymph percolates through immune tissue, allowing for surveillance and initiation of immune responses. This is a major function distributing immune cells and presenting antigens.
Ultimately, where does all this collected lymph end up?
The smaller lymphatic vessels converge into larger and larger trunks, finally collecting into two main ducts. The largest is the thoracic duct, which collects lymph from the entire lower body and the left side of the upper body and head. It empties into the venous system near the junction of the left internal jugular and left subclavian veins. Lymph from the right upper body drains via the smaller right lymphatic duct into the corresponding veins on the right side. So all that collected interstitial fluid eventually gets returned to the blood circulation.
So key roles: fluid return and immune transport.
Exactly. It prevents edema by draining excess fluid and protein, and it's a highway for immune cells and antigen sampling.
This brings us to the final clinical application, lymphedema, which happens when this drainage is blocked.
Right. This is a significant problem, often after cancer surgery. Because cancer cells can spread, metastasize, via the lymphatic system, surgeons often remove regional lymph nodes draining a tumor site to check for spread and prevent recurrence. For example, axillary nodes in breast cancer.
But removing the nodes disrupts drainage.
It can severely compromise lymphatic flow from that region, like an arm or leg. If the remaining lymphatic pathways can't compensate, the protein-rich interstitial fluid accumulates, leading to chronic swelling, tissue thickening, and increased risk of infection, the condition known as lymphedema. It highlights how vital that lymphatic drainage is.
What a journey. 150,000 kilometers covered from the detailed structure of the SA node cells, the insulating fiber skeleton, the elastic lamellae of the aorta, the Weibel Palade bodies popping out P-selectin, the 80 nanometer fenestrations in kidney capillaries, the discontinuous basement membrane in liver sinusoids, the valves in veins, the anchoring filaments of lymphatics. It's an incredible level of specialized structure.
It really is. And if there's one unifying principle for achieving that elite mastery we talked about, it's recognizing that structure dictates function at every single level. You can't truly grasp blood pressure regulation without visualizing the smooth muscle layers in an arteriole. You can't understand coordinated heart pumping without seeing the Purkinje fibers and the insulating skeleton. The specific capillary type an organ uses tells you volumes about its function. It's all interconnected, a constantly adapting, structurally and functionally integrated network.
Absolute mind-blowing complexity, yet elegant in its solutions. Okay, to wrap up and leave you, our listener, with something to really think about, connecting this deep dive into histology with real-world consequences. We've seen how pivotal the endothelium is regulating clotting, inflammation, blood flow, through all those secreted factors. So here's the question. If you had to pick one endothelial function that, if suddenly and severely compromised, would be the most immediately catastrophic for survival, especially in a high-stress demanding environment, which function would it be and why? Think about that intricate balance. That's something to ponder as you solidify your mastery of this incredible system.